Testing. 1, 2, 3.
Mic check. All right. So, welcome to this special episode of Fysi Podcast. I'm really excited about our guest today. I think we will see or hear a couple of controversial meanings and probably some strong language that at least he's warning in his own podcast, the Physionath podcast. Should I say it? Wait. Our guest today is Adam fucking Meakins. Boom.
Round of applause. Hello. Thanks for inviting me on, Frederick.
I'm very glad that you can join us. So is there anything you would like to add or say before we dive into our questions today?
No, you fire away.
All right, let's start off soft. Favorite food?
Favorite food?
Yes.
This is not the questions I was expecting, Frederick. I thought this was going to be physiotherapy stuff.
Of course it will.
No, good. Food, okay. Favorite food? I think curry. I like curry.
All right, nice. Favorite beer?
All of it.
All of it? Yeah. Okay. Fair enough. What about the favorite series to watch? Like Netflix?
TV series?
Yes.
I'm going through one at the moment called The Last Kingdom on Netflix.
All right.
So it's about the history of the United Kingdom back in medieval times.
All right.
And apparently it was all about the Norwegians and the Danes coming over and invading our country. Okay. So it's you lot, yeah.
Yeah. Legit.
Invading our country.
Okay, last one. Favorite book of the easy ones?
Favorite book?
Yep.
I think I've just finished reading The Human Species by Duval.
Okay, cool. All right, so let's dive into the physiotherapy questions. So, how is physiotherapy affected, or how has social media affected physiotherapy, in your opinion?
I think it's made it more accessible to, obviously, the general public. So the general public know us now more because of the social media effect. Mm-hmm. I also think it's allowed difference of opinion to be more widely accepted not accepted. I think difference of opinion has been more widely promoted. Mm-hmm. So whereas before, a lot of ideas and opinions were only talked in small groups between individuals, now we've got social media. It's out there in the open for lots of people to recognise there's other views, other opinions about what's going on.
Yep. Do you have a couple of concrete positive examples how social medias have influenced physiotherapy?
Yeah, I think, from my perspective, the way that social media has affected me personally is that I am now doing these courses.
Yep.
So before, the only people that used to teach courses were professors, were academics.
Indeed.
And very rarely would you see a clinician actually going out teaching a course. Mm-hmm. So I think that's a positive. I think, again, listening to clinicians more about what their experiences are actually on the front line, rather than just academics and researchers teaching us what we should be doing based on what they find in laboratories, I think is hugely important.
Yeah, that's true. On the social medias, there's a lot of don't do this, don't do that. Why do we focus so much on the don'ts?
Yeah, good question. I think, again, it's just fear. A lot of people are fearful about, causing more pain, causing more damage, causing more harm. Sure. And I think we still have to be sensible. Mm-hmm. I do think there is a role for us sometimes saying to some individuals, stop. Yep. Like we talked about today, there are some people you just have to say, you're doing too much, just relax a bit, calm that shit down. Yep. We'll build it back up later on down the line. So I think there is a role for us to say to people, don't. Indeed. But I do think there's also a lot of it given to other people that is unnecessary and is fearful. And again, it's just a misunderstanding of what pain is. I think that's the biggest thing. A lot of us always still think that pain is damage, is something that's broken.
Yeah, true.
And we know now that's not the case.
Indeed. Is it easier to say, don't do that rather than do it?
Yes and no. Again, I do find, sometimes it is probably the easier path to take, to say to somebody, just don't do it anymore, stop doing it.
Yep.
Rather than trying to get somebody to carry on doing something they don't want to do or something that does hurt. Yeah, I'm sure it is, yeah.
Yeah. Okay, top 2 influencers that shaped you as a physiotherapist.
Top two.
Yep.
Well, I think going way back in my early career was Louis Gifford. So Louis, back in the sort of early 2000s, had a huge influence. I'd just say I went on one of his courses, and he gave me the faith that physiotherapy could be a profession for the good, because I was very disillusioned with it. In my early career, when I graduated, I almost stopped being a physio. I thought I'm going to try and find something else to do, because I really didn't enjoy it. Yep. I was finding, again, lots of myths and misconceptions. The way that I was practicing and helping people in pain, I found very awkward. Yeah. But say, I went on Louis' course and very much changed my belief in the role of physiotherapy. And then I think the next one, I'd probably have to give a shout out to probably Tom Goom, the running physio. Yeah. He probably might be a bit surprised about this, but he influenced me because of the benefits of social media. So again, back in sort of, I'd say probably the early 2010s, you know, about 9 years ago, 10 years ago, I was only just getting involved in social media, and I didn't see much benefit from it until I saw Tom Goom. Oh, yeah. And so he sort of triggered my thinking to say, right, no, this could be used for a benefit and a good cause. So I've got to give him credit as well. Yeah, nice one. I like those two guys as well. I talked to a friend who works with a lot of shoulder patients, and I asked him, "What would you ask Adam Meakins?" And he wondered, how do you explain subacromial syndromes to patients? Great question. No simple answer. So I think the subacromial painful shoulder is a controversial area because, again, can we reliably identify where the pain is coming from, the source, the structure? There are lots of potential suspects, lots of different structures that could be causing subacromial shoulder pain. So I think the simplest way that I try to describe subacromial shoulder pain to patients is that it could be your rotator cuff, it could be your long-headed biceps, it could be the bursa, it could be the acromion contributing. There's all these potential suspects, but a lot of the time we don't know exactly which one it is, but it doesn't matter. Indeed. Because, you know, at the end of the day, our treatment, our management isn't guided by the structural diagnosis. It's guided by what we gain from them in the history, what we gain from them in the examination, and also their response to what we ask them to do. Yeah. Do you usually dive into the anatomy and explain this stuff? Sometimes. Again, I find some patients want a little bit more information. Other patients are not interested at all. So again, with everything, it's all about, you know, what does the patient want? Do they want that sort of more structural explanation? Then I do try to give that sort of explanation that it's not easy to give a structural diagnosis. Other patients don't care. All a lot of other patients want to know is it safe? Is it okay to move? And so then I'm not using any of these sort of structural diagnosis or, you know, medical terms. All right. I think it's time to do a cheers. Do you know how to say it in Norwegian? Skål. Yes, sir. Okay. Skål. Skål. Cheers. Okay. We say bottoms up. Bottom up. But if we do bottoms up, we kind of get a little sleazy in the language. At least I do. Okay. Which exercise do you prescribe the most for your shoulder patients? Probably just lifting the arm up and down. Okay. Sure. Elevation of the arm. Elevation of the arm. In lots of different angles, lots of different varieties, lots of different weights, lots of different speeds, different hand positions. But yeah, normally, again, most people with shoulder pain can't lift their arm up and down. That's what they need to do. They need to be exposed to that movement. Even though it's painful? Yeah, again, sometimes it's good to push some patients into pain. Other times it's not. Yeah. True. Again, you've got to use your history and your examination to decide, do I push this patient into pain or don't I? Yeah. And the key factors there are, again, their beliefs, their attitudes, the chronicity, the severity of their pain. These things will all guide you as to deciding whether do I push somebody into pain or don't I? Yep. Okay, so I just finished my bachelor degree, and we learned a lot of outdated shit, to be honest. Where does where does the physiotherapy transform, or where is the change happening? Because it's certainly not happening at bachelor level,
does it happen at master's, PhD? Where's the change?
Unfortunately, it won't change through academia. It's going to have to change through clinicians pushing and driving academia to up its game, to sort of recognise that a lot of bachelor's degrees, master's degrees are still stuck 10, 15 years down the line, and they need to be challenged more, and they need to be trying to get people a bit more engaged with current evidence. Unfortunately, I find, again, academia, it's hard for them. I'm not going to, say it's easy. They are stuck in a system that very much governs what they can and can't do. And I think until that system changes, until the politics around it changes, that's the big thing, is the politics, the vested interests. Until that stuff changes, not a lot else will do.
Yeah. There's been some talks about, at least in Norway, to change the physiotherapy into a 5 years long study. What do you think about that?
No, I don't agree with that. I think, again, I think there's too much waste around the education about what we're training physios to focus on. I think we can make it a lot more simpler, straightforward, get them focused on the things that really matter, and still do it in a good time frame. I mean, doctors take 5 years to train, and they have to know a shitload more information than physiotherapists do.
Yeah, true.
Not knocking physio information and training, but there's no way that I think a physio needs to train to the same extent as a doctor does. Yeah. And that's the other thing. I see a lot of physio masters or bachelor's programs only accepting people onto their programs who could potentially be doctors. They ask for the same sort of grades, and I don't think that's right. I think we're missing a vast swathe of the people that could potentially be very good physiotherapists, but they're excluded because of these very high entry requirements that are gained from.
Yeah, it's the exact same thing going on in Norway. It's crazy. Yeah. Okay, next question. In your opinion, which profession is the best cooperative to physiotherapy? Do you have like one of the professions when you work interdisciplinary, you kind of fare more, or do you cooperate better with? Manual, we're getting there. Just wait.
I cooperate with a lot of other professions. Is one more better than the other? No, I think, again, it's individuals. There are people in certain professions that are more engaged with working with other professions than there are others. So, no, I work with surgeons, I work with doctors, I work with nurses, I work with dietitians, I work with personal trainers, strength coaches. So I've got a big network that I sort of utilise, that I will pass patients over to who I think are better served by these individuals rather than me, and vice versa. It's a lot of the times my personal trainer friend is referring colleagues to me because somebody's got pain and they want me to check it out. They want to make sure it's safe for them to proceed. So no, I wouldn't say there's one profession that's better than the others.
Okay, good answer.
And that goes for manual therapy as well, because I work with manual therapy. I work with masseuses. I work with soft tissue therapists as well. Because I don't use it, I know that some patients want it. And so I need somebody to signpost them too. Yeah. So I do work with manual therapists as well.
Yeah, indeed. There's like the controversial saying you have, like, manual therapy sucks.
Yeah.
Why does it suck?
Because of the nonsense around it. Because of the overcomplicated bullshit, the crap that goes around it. People, claiming that they can do things which are just ridiculous.
Yep.
So I think if manual therapy was just a little bit more simpler, if people were a little bit more open and honest about what it can do and what it can't do, I'd be more relaxed about it. I wouldn't go around telling people it sucks. I think, it's just, let's get some sense, common sense.
Okay, but what is manual therapy? Is touching your patient manual therapy?
Yes and no. So you do need to touch patients. I think, we have to examine them thoroughly.
Yep.
And part of the examination is palpation. So we need to do the basics well. We need to make sure that when we palpate people, there's nothing broken, there's nothing deformed.
Yep.
There's nothing that's hot or swollen.
Yep.
That's just doing the simple stuff really, really well. So, and that matters to patients when we touch them. We need to make sure that we give that patient the reassurance that we've examined them thoroughly.
Yep.
And part of that is touching somebody. The amount of times I hear a patient tell me that the doctor or somebody didn't even ask them to undress the area. They didn't even look at it.
Oh, yeah?
Yeah, they've just passed them on to somebody else or referred them. They didn't examine it. So I think palpation is important, but do we have to use manual therapy as physiotherapists? No. Our profession is not dictated or governed by our interventions. Do we always have to use electrotherapy with our patients? No. Do we always have to use exercise therapy with our patients?
Well, yeah, maybe. It depends.
My bias is yes, okay, but you know, technically, I would also say that falls under the same remit. Our physiotherapy is a profession to help people in pain to move more. So we do have to encourage movement, but you know, do we always have to use exercise to get them to do that?
Yeah, good point. Do you go to physiotherapy if you're in pain?
No.
Why?
Because I know. Because I've got knowledge that says that most of the time the pain I know that I feel from time to time, like my right elbow at the moment, that hurts a bit, I know it's safe. I know that there's nothing that a physiotherapist is going to tell me that I don't know already. But patients aren't physiotherapists. Patients don't know that pain is safe. So we are here to fill that void. But yeah, if I had a few physiotherapy patients, I am a little bit concerned when a physiotherapist is coming to see somebody else for their problems. I'm like, what's your problem?
Okay.
Why aren't you able to self-evaluate and self-assess and self-manage yourself?
Yes, I know. There is a wide spectrum of physiotherapy, though. Like a person who's been practicing in a hospital with lung physiotherapy for 30 years don't know these things, as good. But but still, I get your point. So what's the coolest thing about being a physio?
The coolest thing?
Yeah, like what gives you energy about the physiotherapy? What's so cool about it?
Okay, I think helping people in pain and distress. I think, you know, somebody that's got a lot of fear, anxiety, being able to, you know, make them feel more robust and resilient is a cool feeling. You know, to get somebody who hasn't believed that they're able to bend over and pick something up for 5 or 6 years because of somebody else is telling them that. Being able to see that change, I think, you know, it's a rewarding sensation. And when patients come back to you and say, I've never thought I'd be able to do this again. Yeah, that is one of the best feelings as a physiotherapist, definitely.
Yeah, indeed. Okay, last question. If you were to choose all over again, your study, what focus you had during your study time, what would you choose today? Like in retrospect, now you know, based upon what you know today.
That is a great question, and I have thought about this a number of times, and I think if I'm being honest, my profession that I probably would have gone into now if I could go back would be something outdoors. It would be something in nature, and so I'll probably say that I'll probably be a tree surgeon. Or working in the Forestry Commission.
Oh, nice.
So I've got a friend who does that, and I've done a couple of weekends helping him out, and I have found myself thoroughly enjoying it. So, yeah, if I could go back and do it all over again, I would probably say I'll be a tree surgeon.
Great answer. Okay, I want to give the opportunity. Do you have any questions? If you have any questions, I'll repeat into the microphone and ask it.
I can ask.
Okay, a question?
Yeah. So is this related to acute treatment of musculoskeletal injuries? So we have these principles that we use PICE or ICE, that stands for protection, ICE, rest. So we have police, ICE, rest. Which how can you say, which one do you use? Which one is the most the best? Do you understand what I'm trying?
I do, yeah. So for an acute injury, I think again it is simple as just saying, you know, it needs a period of protection. So I do think that is part and parcel of it. So for something, you know, that's really acute, really severe, I don't think it needs much ice or compression. It does need optimal loading. I think it does need optimal loading. Yeah. So I would probably go with a sort of saying police is a good analogy that I would use. Yeah, protection, optimal loading. But even then, I'd probably say don't worry about the ice. Compression, something grossly swollen can help a little bit. Elevation as well. So I'll probably say police but without the I. What's that?
Yeah. Okay, police
without the I. But yeah, I've seen the other one. What is it? The other one, Peace and Love. Have you seen that one? Yeah. That's the new one that's come out at the moment. People are just trying to reinvent the wheel by using all these different acronyms. But yeah.
Okay, thank you so much for being on Physio Podcast. I have to thank you for a great course. The physiotherapy complex doesn't have to be complex at Trimmen here in Drammen. Thank you so much, and looking forward to follow your social media posts further.
Thanks very much for inviting me on, Frederick. Should we go and have some more beer?
Indeed.
Yeah.
Okay, thank you. Goodbye.
Cheers.